My name is Dr. Michael Kent. I'm a surgeon. I've been one for 22 years. I have spent more mornings than I can count walking into an operating room before the sun comes up and walking out after it's gone down. I have seen surgery do extraordinary things, things that used to end lives that we can now fix. And because of all of that, because I know this world from the inside, I need to tell you something that most of my colleagues won't say out loud. There are 5 surgeries that in most situations I would not recommend to my own parents. Not because those surgeries are wrong, not because surgery isn't sometimes the only answer, but because I have watched too many times what happens when a body over 65 faces certain surgical procedures under certain conditions. And what I've learned changes how you should be thinking about your health or the health of your parents right now. In this video, I'm going to walk you through all 5. I'm going to tell you exactly why the risk multiplies after 65 in ways that have nothing to do with how healthy someone looks. And I'm going to tell you what to do instead. And because there is almost always something to do instead, this is the conversation I have with my own family. I'm having it with you now. Before I get to the list, I need to give you a framework because without it, the 5 surgeries won't make complete sense. The framework is a single medical concept, and it is almost never explained to patients outside of a research journal. The concept is called frailty. Now put aside the age on someone's driver's license completely. Frailty is not the same thing as age. Frailty is a medical term for the body's reserve, its biological buffer, its capacity to absorb a massive physical shock and recover from it. Here's how I want you to picture it. Imagine your body is a battery. When you're in your 30s, that battery is fully charged. You can work late, miss a night of sleep, catch a virus, eat badly for a week, and your body absorbs all of it. You bounce back. The reserve is enormous. As the decades pass, that reserve naturally decreases. By your mid-60s, perhaps you're at 60 or 70%. And here is the critical thing I want you to hear. 60 or 70% is completely fine for daily life. Absolutely fine. You walk, you cook, you travel, you feel well. The daily draw on that battery is well within what it can handle. But a major surgical procedure is not a daily draw. A major surgery, general anesthesia, significant incisions, the trauma of healing is more like plugging an industrial appliance into a household outlet. The daily battery handles daily life. Surgical stress is something categorically different, and in a body that's already at 60%, that kind of drain can bring the battery to zero. Think about the last time you had a serious illness, not a cold, but a real flooring flu, the kind where standing up felt like an event. Your body was essentially preoccupied with fighting one thing. Now imagine that during that week, someone needed to make a significant surgical intervention and ask your body to simultaneously fight, heal, and restore normal function. That's not what surgery is. But the gap between how you feel on a normal Tuesday and how your body performs under genuine surgical stress, that gap is what frailty measures. And here's what makes this harder. Frailty is invisible. You cannot see it in how someone carries themselves or how active they seem. A 72-year-old can be biologically robust, while a 68-year-old can be genuinely frail. Researchers at Johns Hopkins studying over 500 elderly surgical patients found that frailty predicted post-operative complications, hospital readmissions, and whether patients ended up in long-term care far more accurately than their chronological age alone. So, the age on the form tells you very little. The body's reserve tells you everything. Now here is the second piece of the framework, and it's the one I most need you to remember. The real danger is almost never the planned surgery. It is the emergency surgery. The surgery that happens because something manageable was left alone until it became a crisis. I want to give you a comparison that I think makes this visceral. A planned surgical procedure is like landing a plane on a clear day with a full fuel tank, a prepared crew, and a runway that's been inspected. An emergency surgery is landing that same plane in a storm with a depleted fuel tank in the dark on a runway nobody checked. The outcomes are not comparable. Emergency abdominal surgery in adults over 65, even in those who are not particularly frail, carries in-hosp mortality rates that hover between 7 and 15% depending on the procedure and the study. In patients who are frail, published research has documented those figures climbing to 25% and beyond. That is not a statistical abstraction. That is 1 in 4 people. And the reason those numbers matter so much is that most of what turns into emergency surgery starts as something that was entirely manageable, a problem that had a scheduled solution that was ignored or normalized or waited on until it became a catastrophe. That is what connects every surgery on this list. Now let me walk you through them. The first surgery is the emergency colectomy. the removal of part or all of the large intestine performed under emergency conditions. Let me explain how a person gets here. The colon can develop serious problems as the body ages. Diverticulitis, small pouches that form in the colon wall and become inflamed or rupture. Colon cancer, which in a significant number of cases grows for years before producing any symptoms strong enough to bring someone to a doctor. Inflammatory bowel disease that crosses a dangerous threshold. In a planned, prepared surgical setting, a colon resection performed laparoscopically through small incisions guided by a camera has risks that are real but manageable. The surgeon can evaluate the patient, optimize their condition beforehand, time the procedure carefully. Emergency colectomy is a fundamentally different operation. When a diverticular pouch ruptures or when an undetected tumor causes an obstruction or perforation, intestinal contents, bacteria, waste enter the abdominal cavity. This is peritonitis, a systemic infection that is lethal without immediate intervention. By the time this arrives in an emergency room, the patient is often already in early septic shock. There is no preparation time. The abdomen is opened urgently. The contaminated field is cleaned. The affected section of colon is removed. For a body whose biological reserve is already reduced, this is not a manageable insult. It is a near catastrophic one. A large-scale analysis of elderly patients, those over 65, undergoing emergency colorectal resection, found overall in-hosp mortality approaching 16%. In frail patients, multiple published studies documented mortality rates exceeding 25%. Complication rates in survivors, pneumonia, kidney stress, wound breakdown, were substantial. Now, I want to offer you a moment to actually connect this to real life. Think about the last time you or someone close to you noticed something mildly off, filed it away, and assumed it would resolve. Not a sharp, dramatic symptom, just something quieter than that. A shift in how the body was working that was easy to attribute to diet or stress or just getting older. And the weeks kept passing. That response, I know how reasonable it feels. I do not say this to judge it. Most of us handle our bodies this way most of the time, and most of the time it works fine. The body is remarkably self-correcting. But colon cancer and diverticular disease do not self-correct. They progress, and the window between this is something we can address with a scheduled procedure, and this is a middle of the mortality rate can close quietly and without much warning. The good news here is genuinely good, and I want you to hold on to it. Colonoscopy from age 45 or 50 gives your physician direct visualization of the entire colon. Precancerous polyps, the cells that over years become cancer, can be removed in the same procedure. This is a sedated outpatient process. The colonoscopy itself is the alternative. It is the intervention that converts a potential catastrophe into a Tuesday morning appointment. A diet consistently high in fiber, vegetables, legumes, whole grains combined with limited processed meat reduces colon cancer risk through mechanisms we understand well. 30 minutes of walking most days independently reduces risk. These are not lifestyle suggestions offered vaguely. They are the upstream interventions that reduce the likelihood of ever arriving at this decision point. If you notice persistent changes in your bowel habits, blood where it shouldn't be, unexplained weight loss, or abdominal pain that keeps returning, please do not normalize it. Those are signals. They deserve a response. The second surgery is the emergency repair of a perforated peptic ulcer. A peptic ulcer is an erosion, essentially an open wound in the lining of the stomach or the upper portion of the small intestine. The two most common causes are the bacterium Helicobacter pylori, and particularly relevant to older adults, the chronic use of non-steroidal anti-inflammatory drugs, NSAIDs, ibuprofen, naproxen, aspirin taken regularly for arthritis or joint pain. NSAIDs work by blocking prostaglandins, chemical blocking prostaglandins, chemical signals that drive inflammation. The signals that drive inflammation. The issue is that prostaglandins also maintain the protective mucus lining of the stomach. When you suppress them, when you suppress them regularly, that protection thins over regularly. That protection thins over time. The stomach acid that is always present begins eroding the tissue. Beneath. Most ulcers identified early are treated without surgery. NSAIDs are treated without surgery. Proton pump inhibitors omeprazole, pantoprazole reduce acid production and allow the ulcer to heal. If H. pylori is present, a short antibiotic course eliminates it. In the vast majority of cases, the ulcer closes, no operating room. The danger arrives when the ulcer is left untreated, deepens, and eventually perforates, breaching completely through the stomach wall. The acidic contents of the stomach enter the abdominal cavity directly. The pain is described as sudden and absolute. A chemical peritonitis begins immediately. There is no non-surgical path from this point. Published 30-day mortality data for elderly patients undergoing emergency perforated ulcer repair places. The rate between 15 and 25% across multiple studies. Postoperative complications, acute kidney injury, respiratory compromise, postoperative delirium affect a substantial proportion of survivors. Here is the moment I want you to pause on. Think about how someone yourself or a parent or someone you care about typically manages taking an over-the-counter pain medication every day. Ibuprofen for a bad knee. Naproxen for a shoulder that never quite healed. It's sold without a prescription. It's familiar. It's been in the medicine cabinet for 15 years. There's no warning on the label that seems alarming enough to prompt a doctor's visit. I'm not saying that to frighten you. I am saying it to offer you a specific concrete reframe. Chronic daily use of an NSA in someone over 65 without a gastric protecting medication alongside it creates a genuinely measurable risk, not a theoretical one. One that multiple studies have documented with real numbers. The conversation to have with your physician is simple. I take an anti-inflammatory regularly. Should I be taking a proton pump inhibitor alongside it? That one question, and the answer to it, may be all that stands between your current situation and a surgical emergency with a 1 in 4 chance of a fatal outcome. The third surgery is the emergency resection of the small intestine, an enterectomy. The small intestine is where your body absorbs nearly all of its nutrition. When something cuts off blood supply to a portion of it, the consequences accelerate rapidly and are very difficult to reverse once they advance beyond a certain point. Obstruction of the small bowel can result from scar tissue left by previous abdominal surgeries, a hernia that becomes entrapped, or other structural causes. Loss of blood flow. Mesenteric ischia typically occurs when a blood clot lodges in one of the major arteries supplying the intestine. This is substantially more common in people with cardiovascular disease, atrial fibrillation, or clotting disorders. And if the affected portion of intestine is extensive, removing it can result in short bowel syndrome, where the remaining intestine simply cannot absorb adequate nutrition from normal eating, requiring long-term intravenous nutritional support. That is not a temporary outcome. That is a permanent change to how someone lives. Now, here is where I want you to make a personal connection. Think about how most of us respond to stomach cramps, nausea, and vomiting. The first assumption you're almost universally is that we ate something that disagreed with us. We give it a day, we stay close to home, we drink water. Most of the time, this is exactly the right response. A stomach upset resolves. But in an older adult who has had previous abdominal surgery or who has a known heart condition or atrial fibrillation, that same symptom cluster, cramping, nausea, vomiting that doesn't resolve, can be the early presentation of a bowel obstruction or intestinal ischia. The difference in outcome between catching this at 6 hours and catching it at 48 hours is in some cases the difference between a conservative hospital admission with an IV and losing a substantial portion of the intestine permanently. I am not suggesting that every stomachache warrants an emergency room visit. It doesn't. But I am saying this clearly. In adults over 65 with prior abdominal surgery or significant cardiovascular history, abdominal pain that persists beyond a reasonable window, especially with vomiting, deserves a medical evaluation. A CT scan can provide a diagnosis in minutes that distinguishes something benign from something that requires immediate action. The fourth surgery is one that might genuinely surprise you because these are two of the most common operations in the world: appendectomy, removal of the appendix, and cholecystectomy, removal of the gallbladder. I'm not saying these surgeries are dangerous. In most cases, they are not. I'm saying that the delay is dangerous and older adults are uniquely, specifically vulnerable to a pattern that turns a routine surgery into a major one. Here is the medical reality. Appendicitis in a younger adult is rarely subtle. It announces itself with a localizing pain in the lower right abdomen, fever, nausea that escalates in a way that is very difficult to ignore. Most younger people are in an emergency room within hours. The appendix comes out before it ruptures. The surgery takes about an hour by laparoscope. The patient goes home the following morning. In adults over 65, the same condition frequently presents with symptoms that are diffuse, mild, and easily misattributed. The pain may be vague, there may be little or no fever. The classic presentation doesn't show up, and so the response, completely understandably, is to wait and see. By the time the clinical picture becomes undeniable and the person reaches an emergency room, the appendix has often already perforated. The infection has spread from a contained removable structure into the entire abdominal cavity. What would have been laparoscopic surgery with same-day discharge becomes open surgery requiring abdominal washing, drainage placement, and a recovery measured in weeks rather than days. The mortality for uncomplicated laparoscopic appendectomy in any age group is less than 1%. Perforated appendicitis in older adults carries documented mortality rates of 5 to 10%, rising sharply in those who are frail. The gallbladder follows the same pattern. Early cholecystectomy for acute colixitis is manageable. A gangrenous gallbladder with surrounding inflammation is not. Here is the recognition I want you to sit with for a moment. Think about how you or someone you're close to tends to handle a new, unfamiliar discomfort. The first response for most of us is patience, a bit of rest, something mild from the medicine cabinet, a private hope that tomorrow will bring improvement. This is a completely sensible and usually appropriate approach. It saves thousands of unnecessary healthcare visits every day. The distinction I want you to understand is this: abdominal pain that is genuinely new, that is not clearly explained by something you ate or a known pattern, and that persists beyond a day in an older adult, that is not a candidate for continued watchful waiting at home. It is a candidate for evaluation. Because the older nervous system does not always report pain at the intensity that reflects the underlying severity. A 4 out of 10 in a 70-year-old's perception may be a 7 out of 10 in the biological reality. Act earlier rather than later. That is the entire safe alternative for this surgery. The same procedure performed 24 hours sooner is categorically different in outcome. For gallbladder prevention specifically, a Mediterranean-style dietary pattern rich in vegetables, olive oil, legumes, fish, and whole grains is associated in observational research with reduced gallstone formation. Maintaining a healthy body weight meaningfully reduces gallbladder disease risk over time. The fifth entry on this list is different from the others. Every surgery we've discussed so far carries a clear instead of emergency, plan earlier. Instead of delay, act sooner. This one is different because often you cannot avoid the surgery itself. A hip fracture needs repair. A lung tumor needs to be addressed. The surgery is coming. The question is not whether, it is how the patient arrives at it. Let me give you the numbers first because they deserve to be stated plainly. 1-year mortality following hip fracture in adults over 65 ranges from 17 to 25% across major published studies. Individuals who sustain a hip fracture face a 3 to 4 times higher risk of death compared to age-matched peers who did not. And a substantial proportion of those who survive never fully recover the level of independence they had before the event. Hip fracture is not simply a painful orthopedic injury that happens to require a big operation. It is a physiological event that reveals something was already significantly depleted. Bone density, muscle mass, balance systems, cardiovascular reserve before the fall ever happened. Major thoracic,